So the next topic that we have for the symposium today is aortic aneurysm treatment options. And they're going to be shared by Dr. Adam Defoe. Dr. Adam Defoe is an interventional radiologist at Essentia Health. He obtained his medical degree from the University of North Dakota School of Medicine and Health Sciences. He completed his residency in diagnostic radiology at Creighton University, and he is board certified by the American Board of Radiology in interventional radiology and diagnostic radiology. So Dr. Defoe, please join me.
Thank you for that introduction. So like I said, I'm Adam Defoe, interventional radiologist at Essentia. Raise your hand if you know what interventional radiology is. Oh, that's more than I expected. So that's good, but we can explain it a little bit here. Maybe. So the interventional radiology, the name really says it all. So interventional basically means that I do procedures, and the radiology part of it means that I use imaging to do these procedures. So whether it's a CT scanner, ultrasound, or live X-ray, also known as fluoroscopy, to do procedures. And because I get to use the imaging, I can do things in a minimally invasive way. And so we do procedures all over the body, including the vascular system, so the arteries and veins of the body, whether it's to remove clot from those, to open them up, or to stop bleeding, and including treating aneurysms like in the aorta. And the picture you see there, those gentlemen are working under fluoroscopy, so that live X-ray, they're doing an angiogram, so they're injecting some contrast dye into a blood vessel so they can see it under the X-ray to do some sort of intervention. Now that that's out of the way, here's a little roadmap of what I'll be talking about today with respect to abdominal aortic aneurysms, also known as AAA. So just some anatomy, and I know there was already an aortic talk which I wasn't able to attend, but so we have blood vessels in our body, the tubes that carry the blood, the arteries carrying that oxygen-rich blood away from the heart, and the veins carrying it back to the heart. And the biggest artery we have in the body is the aorta, comes straight off the heart, as you can see there, going right down the middle, down the chest, and then into the abdomen. So the top part, that's the thoracic aorta, and then as it goes below the rib cage into the abdomen, that's the abdominal aorta, and that's what we're focusing on with my talk today, is that abdominal portion of the aorta. And as that diagram shows, it can be too big or what we call aneurysmal. And so what is an aneurysm? Well, the strict definition is enlargement of a blood vessel to 50% greater than its normal size, or normal diameter. So for most adults, once that gets above 3 centimeters, that's when we call it an aneurysm. For most adults, the aorta can be about the size of a garden hose, so about an inch or so. It does vary with age, whether you're male or female, and of course, your body size. If you take 100 people and you look at their aorta size, 95 of them will have an aorta that's under 3 centimeters, so non-aneurysmal. All right, so just how common is aneurysms of the abdominal aorta? So about 2 to 8% of the population might have it at any given time. It is higher in males, so sorry guys. It does also increase with age, and that increase with age is also, we see that more with males than females. Approximately maybe 1.5 million people in the US right now have an aneurysm of their aorta. Approximately 200,000 new cases a year. This fact was a little bit was different based on kind of which source I looked at, but one source did say about 200,000 new diagnoses per year of an abdominal aortic aneurysm. And it's important because if you think about like the weak spot of a car tire, eventually it's going to rupture. And so if an aorta ruptures, that of course can be fatal. And in fact, if your aorta ruptures, you only about a 1 in 5 chance of surviving that event. And because of that, it's the 15th leading cause of death in the US, and in men over 55 is the 10th leading cause. And it causes about 7,000 deaths per year. So that's why it's important to identify it, and so we can hopefully treat it and prevent these deaths from happening. You might recognize this gentleman, Albert Einstein. He actually died of a ruptured abdominal aortic aneurysm in 1955 when he was 76 years old. So surgery for abdominal aortic aneurysm was really in its infancy at that time, so he may have been able to live longer. So risk factors for aneurysms of the aorta. So like I already said, the older age is a risk factor. Being male over female, cigarette smoking is highlighted there. That's a huge risk factor we see in not only developing aneurysms of the aorta, but also for having them progress and get bigger. Family history, also pretty big. If you have a first-degree relative, so brother, sister, mother, father, who has an aneurysm of the aorta, you yourself are 12 times more likely to have one. If you have aneurysms elsewhere in your body, other large arteries, that may signify there's something going on with the walls of those arteries that would predispose your aorta to also enlarge. Atherosclerosis, or general hardening of the arteries, can also predispose you to that. As is high blood pressure, which kind of makes intuitive sense. The more pressure that's coming out of the heart pushing that blood against the wall of the aorta could potentially cause that to increase. So what do these aneurysms do? Well, unfortunately, they tend to progressively just get bigger and bigger. Think of like just keep putting air into a tire, it's just going to keep growing. They're pretty variable on how fast that happens, maybe only about 1/3 of a centimeter a year. So if you're checking someone sort of year to year, you might not see too much, but over 3 years, you might see a full centimeter. Over 5 years, maybe a whole inch of growth. It is faster in smokers as well. So when we follow patients with aneurysms of the aorta, they may stay the same size for years, and then one day all of a sudden they just start to grow. So that's why once we identify one, we'd like to keep on top of it. And so how do we do that? So screening, it's easily accomplished with ultrasound. So as you can see that in the picture there, that's ultrasound sonographer. She's holding the ultrasound probe on the abdomen. That allows her to see inside, to see all the way down to the aorta and to get a accurate size and measurement of it. If you just scan a bunch of people, you'll find an aneurysm in up to 7% of those over 50. The majority of those are small, though. More than half of those are going to be just over that 3-centimeter mark and actually never grow. And so who should be screened? So the top 3 bullet points there, those are taken from the United States Preventive Services Task Force. They make recommendations for screening for all sorts of things like colonoscopies and also for this. And so these are their recommendations based on a lot of data. And so older men who have smoked, older men with first-degree relative with an aneurysm. I guess if you're female, it doesn't matter if you smoked or not. But if you do have a first-degree relative, definitely get screened. And of course, if your doctor is examining you and thinks that your heartbeat's a little bit too strong in your abdomen, it's a good idea to get that checked out. And then also as part of it, a general vascular screening. I've been a part of a couple of vascular screenings that Essentia's put on, and we've done the ultrasound screening of the aorta at that time too, and in the future we'll be doing it again. So in that picture there, that's just an ultrasound image of the aorta. That black circle, that's the aorta. It's really well seen with that ultrasound, and then it's really easy to just get a quick measurement of that. And so a little bit more about the imaging. So like I said, ultrasound, but we can also use a CAT scan to do it. In this image, we see the aorta kind of from the side approach and can be measured sort of from front to back to get another size dimension there. Once we identify an aneurysm, we're typically going to look at it every year with either ultrasound or a CT scan. And so this is just a kind of representative image of a CT scan we might see. So in the bottom corner here, it's sort of a slice of a CT scan, so we're slicing right through someone. That bright white circle there, that's the aorta. That one is definitely aneurysmal. It's about 4.5 centimeters, getting close to the point where we might think about treating that. And with the CT scanner, we can make these wonderful 3D reconstructions, which gives us a lot more information when we're going to treat these aneurysms. So a lot of good information we have with CT. Once we get closer to the size where we're thinking about treating, everyone's going to get a CT scan so we can know exactly what we're getting into. So when do we treat? So it's all based on size. They've looked at a lot of people with abdominal aortic aneurysms over the years and come up with basically at what size are they more likely to rupture? When does the risk of that go up? So below 5 centimeters, the risk of rupture is very low, less than 1% certainly. But once you start to get above centimeters for both men and women, that risk starts to creep up. So that's our cutoff for treatment based on size. Also, if we see it growing, 0.5 centimeter in 6 months or a full centimeter in a year, if that's what we're looking, that's also an indication that it's probably going to just keep on growing. So we'll treat it then as well. if there are symptoms from the aneurysm, so most likely that's pain in the abdomen, back, or flank that we just can't attribute to anything else. We think it's from the aneurysm. Or sometimes in a CT scan, we can actually see signs of inflammation around the aneurysm. And so that would signify this is more of a, what we call it, an active sort of aneurysm, and that would prompt us to treat it as well to prevent that rupture event. Sometimes these aneurysms, because they're so big, the blood that's flowing through them can sort of swirl, and that can deposit plaque along the walls of the artery, or sort of just like old clotted blood, which isn't a problem in and of itself unless that plaque decides to break off and go downstream, and that could cause some problems in the arteries in the legs or even down into the feet or toes. And so if we think that is happening, that's also a reason why we would go ahead and treat the aneurysm, because we don't want any blockages in arteries in the legs. And of course, if someone presents with a ruptured aneurysm, we are going to treat them, but like I said, it's only approximately 20% survival. Most people don't even kind of make it to the hospital to even have the diagnosis made, unfortunately. So how do we treat it? So medical treatment, so that's when basically we've identified an aneurysm and we're just basically watching it and trying to prevent it from getting any bigger. So medication to treat high blood pressure if they're not already on it. If someone is smoking, stopping smoking is the single greatest thing we can do to slow that progression, because that has been shown, smoking has been shown to speed up the rate of which it will increase. And then we're just gonna monitor the size of the aneurysm, like I said before, with ultrasound or CT scan. So the treatments, we have basically two options. So surgical. Surgery, just like it sounds, big incision in the abdomen there to get all the way down to the aorta and to basically to treat it from the inside. Open surgery like that was the only option for decades. Recovery can take months. And on the converse, we have endovascular treatment, which basically means treating from inside the blood vessel. So that's what we'll talk about next. Endovascular aortic repair, which is what I do, also known as EVAR. And that's where we're going to seal up that aneurysm from the inside using a fabric covered stent, also known as an endograft or a stent graft. There's a picture of one right there. Kind of looks like a pair of pants. So the waistband sort of looking part, that's going to go on the top, sort of above the aneurysm where the aorta is still a normal size. And then those other two parts are going to go down where the aorta splits into its iliac arteries, they're called. And so these come in different sizes, different diameters, different lengths, so that we can adequately treat everyone's different sort of anatomy. 8 different manufacturers are currently available in the US to use for these. And so to put it in, get into both groin arteries, and then from there I have access into the inside of the aorta, and then the work is done under live X-ray imaging or fluoroscopy to make sure everything is in a good spot. And here's just a picture of what it looks like on the delivery catheter. So it's a 2-piece system. That's why we have to go into both groins. And so one piece is loaded onto a catheter there, and then the other piece there, and they come together under the X-ray. They get sealed up together to look something like that. So you can see here we have the aorta, the arteries that go to the kidneys. And so right here, this is the aorta is still a normal size, or at least more normal than the aneurysm we have here. And so it's going to seal up nice top there and seal down here into our iliac arteries so that all the blood flow gets channeled through the graft and none of the blood flow gets into the aneurysm anymore, thereby sealing it up from the inside or excluding the aneurysm from blood flow, thereby eliminating that risk of aneurysm rupture or growth. So that is EVAR. And then open surgical repair. It's been around since 1952. Einstein died in 1955. So basic overview here, big incision there. We're retracting the skin and muscle away, moving the intestines out of the way. The aorta gets clamped to stop the blood flow. And then the aorta gets sliced open. Any plaque on the inside sort of gets scooped out. And then a graft gets sewn in. I am simplifying this a lot because I don't do this surgery, but that's kind of what the end product would look like. Just another diagram showing that. And then the aneurysm, the aortic wall gets sewn back over the graft. And so you have a basic diagram of the surgical graft versus the endograft, and they both accomplish the exact same thing. just to exclude that aneurysm from the flow and just keep the blood flow going through the new graft there. So what are the differences between these? So if you look at how patients do long-term survival, there's no difference, which is great. In the United States, about 80% of treatments for abdominal aortic aneurysms are done the endovascular route. EVAR has been was approved for use first in 1999, so a lot younger than surgical repair, but been around for a while. There is, as you can imagine, shorter recovery with the EVAR, less pain, less blood loss. Usually just a 1 or 2 night hospitalization, pretty much a full recovery in about 3 weeks. Surgery could be up to a week in the hospital, maybe 3 months to recover. The follow-up is more frequent with the EVAR approach. Usually you're gonna get a CT scan about every year, at least for the first 5 years, just to make sure that graft is in a good position and the aneurysm is shrinking down. Surgery, it varies a little bit, but less frequent imaging isn't involved with that. Here's just a CT scan of someone who had an EVAR. We're sort of slicing right through them. You can see the aorta here, which had an aneurysm, and then 2 little circles. Those are the part of the graft where it was split into 2. And so that's a good looking graft on that slice. And that's all I have. Thank you.
Any questions before we proceed?
Yeah, my dissection went from my arch quite a ways down, so I got the Dacron graft in the arch, and then later on I had a huge endograft put in that goes quite a ways down because it was the true lumen and false lumen were both left open for blood flow reasons, and this is something that I've never been told I'm at risk for is an abdominal aneurysm, I guess, and I have a CT scan every year, and it's just something that's never been detected or even brought up, but what's my likelihood of developing some type of abdominal aneurysm?
I guess I can't give you an exact number on that. Dissection is a little different than aneurysm. They both deal with sort of with the wall of the artery, but I mean you're getting frequent scanning, which is good. And so I would say, basically the primary risk factors that I talked about would still come into play. So, smoking, family history, those kind of things are still going to be your biggest risk factors for developing aneurysm in the abdominal aorta.
Rid of a lot of the bad lifestyle habits, and my blood pressure's under control, and cholesterol too. So.
Yeah, so I think you're probably in good shape then. So.
You mentioned that about 20% of the cases are still being done with surgically rather than through the EVAR technique. Is there a reason why that is, or what's the choice in that? What's the decision tree there that's leaving that still at this point today?
Sure. So I mean, every patient is approached individually, and I think the main determinant is if, based on imaging the characteristics of the aorta, if someone looks like they're a good endograft candidate, so to speak, if their anatomy looks like an endograft is going to work really well for them, then I think it's a pretty easy decision to do that endograft because of just a shorter recovery time and things. Not everyone is a great candidate for an endograft, though. If the aneurysm extends all the way up or even past the level of the arteries that go to the kidneys, then surgical repair really might be the only option. Or if the aorta is really angulated, again, the endograft might not quite seal up tight enough, and so that might be another reason why a surgery would be the better option. So basically, it's mostly based on anatomy.
So for the surgery, what are the chances that an aneurysm reappears? Is that even a possibility after the surgery?
Good question. I don't have a definite answer for you, but since that graft is sewn in, I think it's pretty unlikely that you'll have any sort of recurrence of aneurysm, and that's why the imaging frequency is a lot less. So I won't say it's impossible, but yeah, I think it's pretty unlikely.
Anybody else? All right, well, thank you, Dr. Defoe.
You're welcome. Thank you.